One of the magnet requirements is that you have a graphic that speaks to your philosophy of research and innovation or new knowledge in your setting. And of course, we went to the literature and looked at what's out there, but we didn't really care for a lot of the existing models because they were primarily aimed at either just evidence-based practice or aimed at research. And we feel it takes all flavors of clinical inquiry to adequately address the complex and thorny nature of a lot of our clinical issues. So we had to come up with our own model, which is called the UCSF Clinical Inquiry Model. And there's a reason we called it the Clinical Inquiry Model and misspelled it. We do know how to spell. But we called it that because our professional practice model was the AACN Synergy Model. And clinical inquiry is one of the nurse competencies in the AACN Synergy Model. So we thought that was pretty clever to align the name of our research graphic and model to be aligned with it. So clinical inquiry is our model. And as you notice here, patient and family are the very center of the model because everything we do is about them. Even any research question you would ask, at the end of the day, in a healthcare setting, you're asking something that impacts patients and families. Even if you're asking about a staffing model, let's compare this staffing model on demonstration unit A to this staffing model on demonstration unit B, you're still, at the end of the day, looking at patient and family outcomes. So the patient and family are in the center, and then these flavors of clinical inquiry are around the side, and that's what we're going to talk about now. So quality improvement is the first sort of flavor of clinical inquiry, and it's represented as the QU in our model. And that's defined as the deliberate application or implementation of knowledge in local settings that's been previously discovered. So that's a really critical distinction. It's already been found in the literature as being effective in some other setting, or maybe in multiple settings. But you're taking that finding and you're implementing it in your local setting to see if it actually improves outcomes in your setting. You know, context and culture are important, and it may be that what worked in hospital A is not going to work in your hospital B. So you really have to do that kind of work to see if it works for you. And that's a quality improvement activity. And it's vital work. It's as important as research. It is vital, vital work. But it's different than research. So that's why there has to be a place at the table for all types of clinical inquiry activities. This is a workflow. We developed workflows to help clinicians understand the differences between these different clinical inquiry activities. And so if you start at 12 noon and move clockwise around the circle, you'll see that it starts with the patient, family, issue, or problem. That's no surprise, right? We talked about how the patient and family is always in the middle of the model. The next step is to access the evidence, because even if you think you're the first one to have this idea and really no one else has ever had this idea, it's just crazy original, you should still go to the literature and see if anyone else has had this idea, because chances are someone's had something to say about it. It may just be a letter to the editor saying someone ought to do something about this. This is a big problem. But you should go and access the evidence and see what's out there. And then you need to appraise that evidence, because maybe there are 10,000 articles out there, but really if you sift through them, really only 3 or 4 apply to what you're actually looking at in your unit with your kind of patient population and the kind of intervention you're thinking about putting into place. So that appraisal piece is very important. And then you need to gather some baseline data, some pre-data, so to speak, because if you're going to put something in place and test the effectiveness of it, you need to be able to have baseline data against which to compare. So you gather that baseline data, you apply that intervention or the already discovered knowledge to your local setting, and then you gather post data. It sounds so simple. Of course, a rigorous quality improvement project can take a year or longer to put in place, because there are many, hopefully you have many stakeholders. It can be quite complex in terms of the design. And then of course you always want to disseminate your findings and share best practices with others. So this sounds simple, like you would do it over a weekend, but it really usually takes longer than that, because there are multiple stakeholders involved.